Hi, everybody. This is your mentor, Dr. Jaweria Naqi. Welcome to the first session of USMLE Crash Course by MedExam Expert. We're going to be studying about the general USMLE today, about the scoring and everything. And then we're going to do a little bit of gross anatomy, a little bit of genetics. I know this is extremely hard to comprehend and fit into a 2-hour session, but we'll give it our best shot. Okay. So, welcome to the session. Basically, I am a US IMG. I am done with my steps. Now I am just going to apply for residency. So yeah, this is my story. I moved to the US 8 years ago, and then I took my time to give my steps. I was working. Meanwhile, I still do work at an upstate hospital. Um, so yeah. Currently I'm also associated to MedExam Expert for OET. So we give OET tuitions as well. So I'm a speaking mentor over there as well. So, all right. So let's start this session. If you guys have any questions, you guys are easy to just stop me in between and ask me questions. I always tell my students not to wait until the end of the session because they forget their questions and I get, distracted by so much of other stuff. So just ask me the questions in between if you guys have any. All right. Okay, let me just share my screen real quick. All right. Okay, so this is just a quick overview about the USMLE scoring system. I know all of you probably know about it because since you guys are taking the crash course, so my understanding is that you guys are already like halfway through your guys' preparation or almost there because usually people who take crash course are, they already know a lot about USMLE. So I'm not gonna go deep into the details, but let's just give it one read. All right, so USMLE is basically the United States Medical Licensing Exam, as you guys know. Um, if you want to work in the US as an MD/physician, you have to give your steps and then you have to be CFMG certified and then apply for the residency. But nowadays, a lot of countries are giving priority to people who are ECFMG certified, like who have completed their USMLE steps. They are hiring them as their residents. So if you go to some country like, let's say, I'm not completely sure, but I think countries like Canada, um, some parts of Canada, I know Canadian board is different and it's extremely tough, but I think some parts of Canada and a couple countries more, they're exempting their exams if you are already ECFMG certified. All right, so step one is about the foundational medical knowledge, like we all know. So basically what we studied in first year, second year, third year, right? So that is the examination in step one. We don't go deep into fourth year, fifth year because that's basically clinical, right? Okay, so it usually focuses on basic sciences or application. People over here in the US who are the AMGs, American Medical Graduates, they usually take it in their third year after their second year. But obviously, we IMGs, we take it after we are done with our med school. So to each his own, to each her own. If you are obviously an IMG and you're done with third year or fourth year, because I have had friends who in SMC and in DMC that they did their third year and then they gave USMLE. So that's okay too. All right, so it's a 1-day computerized based exam. You pick your pro-med center, you go there. You sit in a cabin, which is, oh my God, extremely suffocating. Okay, it's an 8-hour test. It's divided into 7 blocks. Each block contains up to 40 multiple choice questions, maximum of 280 questions. It's a pass and fail game. There's no scoring. So, I mean, it's convenient now as compared to the previous USMLE structure, which was scored. The subjects we cover are anatomy, behavioral sciences, biochem, microbio, path, pharma, physio, and other topics, which are extremely boring, but we have to do it. So, yes, like I was telling you guys, it's a pass-fail system now. So they don't do the numeric score. And even your test, like the result sheet that you get from UCFMG, it only has either pass or fail. It does not have a numeric score on it. right? Okay, this is it. Preparation strategy. So, again, I would say to each his own, but I followed first aid. UWorld worked for me. A little bit of Kaplan for anatomy here and there. Not too much. Um, and videos I rarely watched. But so there's two kind of people. Is one category of people, they get a lot of knowledge from videos, right? And then there's one kind of people who want everything written in black and white. So I think I fall into the second category. If you guys are okay with watching videos and learning, then it's well and good. Then BRS, Betoma could work for you. But for people like me who want everything written in black and white, who, like I like to make notes and scribble scrabble on my book and highlight the entire book and put sticky notes on it. If you are in that category, the latter one, then I would say stick to the books. If you make notes via watching videos, then the former category would suit you better, right? So, okay. So in conclusion, as you guys know, it's a crucial milestone for students. All right, it just tests your the foundational knowledge. If you were good in your first year of med school, second year, third year, then you're good to go, I guess. These are the recommended sources. Petoma, Sketchy, BRS, UWorld, First Aid. That's about it. So we're done with the intro. If you guys have any questions, you guys can ask right away. If not, then even better. So I'm gonna put up the slides of gross anatomy now because we don't have enough time. I have to cover gross anatomy. I have to cover genetics. I was also thinking of doing like a little bit of, UWorld questions, but I think I would put that in my next session. We'll do a couple of UWorld questions of genetics and anatomy in the next session because I think this session, there's so much to do. So I would just stick to that. Okay, let me share my screen again. How do you get the recorded version? You just joined in. So what you have to do is you have to go on the Med Exam Expert website, type in your ID password, go on the USMLE course, go on the recordings, tap that, and you will get the recording session. It was nothing important. Trust me, you did not miss out on anything. I was just giving my introduction. We were just getting warmed up. It was just an intro session, so I think you're good to go. It was just about the scoring and everything. So if you have any questions, you can just ask me. So you're a fresh graduate who just got your license to practice in the US. So are you an MD or are you just got your a degree is what you're trying to apply? Because you've gotten your license and I think you're good to go, right? Okay. Um, okay, in your country you got your license. All right, that's good, I guess. So you still have to give USMLE for the US. So I think that's why you're here, which is good. Great. So if you guys have any questions, yes, you guys can drop those questions down in the comments as well. You guys don't have to speak up if you guys don't want to. I think I'm enough to speak over here. All right. Oh my God, okay, one more question before I share the screen. Yes, the study material is present in the MedExam Expert website. They have made material from first aid, there's UWorld as well for you guys. There's some flashcards and stuff, like pretty cool stuff over there. So, yeah, I think you guys are good to go. If you guys haven't opened up, because I just opened it before joining in, and there's so much stuff. If you guys just dig in, there's a lot of things you guys can take advantage from. All right, so yeah, do that. Okay, let me just share my screen one more time. What is wrong with this? All right. The recording, okay, Balvasha just texted you guys that the recording would be given to you guys, provided to you guys by tomorrow, so you guys are good to go. So don't worry about the recording, you guys will get it. And it's been just 12 minutes, so I think it's pretty okay. You're good to go. All right. So these are oh my God, you guys have to put it in water, stir it, and drink it. All right, if you guys want to pass anatomy. I cannot emphasize upon how important they are. If you guys are like if you guys have been studying for a long time and if you guys are pros over here and if you guys are very, very near to the finish line and if you guys have signed in for the triplet, taken your dates, then I'm sure you guys know about these 100 most important GA conceptions. Every person who studies USMLE step one, they know about it. Okay, so you have to memorize it. When I say memorize, I literally mean memorize. So these notes, I'll tell Palvasha and I'll tell the group moderators to upload these as well on the website, you guys, so that you guys don't have to go and look on Reddit for the PDF and stuff. So I'll just have them uploaded over there. You guys can go through this. This is what I did for my anatomy, and trust me, I did not need anything else. These are 100 important concepts. It just, it kind of like I was thinking, I was like, okay, shall I do first aid? Shall I do this presentation? Shall I make slides? But then I thought about what is that one thing that I tell you guys about anatomy, and boom, you guys are good to go. So this is that one thing that if I want someone to know about what anatomy is in step one, I would just tell them to go through these notes. And trust me, you're good to go. You don't need Kaplan. You don't need anything else after these. All right. So what we're gonna do is we're gonna go through each page. I'll try to do all the pages. I will try. Trust me, I will try. I know we don't have enough time. I'll give it my best shot. But the thing is that I am going to, the way I would be doing it is, I'm going to tell you guys the questions which come in the paper instead of me just reading the whole thing and, having you guys memorize the stuff. No, I'm not here to do that. I'm just going to tell you that this is how they're going to ask the question. This is how you're going to answer. All right. Let's dig in. If you guys have any question in between, please write it in the chat so that I could just answer simultaneously. All right, so the first topic is the lumbar puncture, which is also called a tap and epidural anesthesia. All of you guys know that lumbar puncture is performed in the subarachnoid space. It is done to extract the CSF, right, which is also known as spinal tap, or inject the anesthesia, which is also known as spinal block. All right, so what they ask you in the exam is they give you a scenario of a person who is, about to like get his tab done, and then they just ask you that at what level the needle would be inserted. So obviously you have to know that L3, L5, or L3, L4, or L4, L5. So it's a tongue twister. So I have seen this question a lot in your world. It comes a lot in NBME. You have to just memorize it. There's going to be four options. Obviously, you guys all know the drill, 4 or 5 options, and you guys have to just know that, okay, this is the level. Sometimes they don't give you L3, L4, L4, L5. They just give you that, the upper point of iliac crest. So you have to know that as well, right? So yeah, this is it. This is what you should know. There's one more question which comes in your world that what are the red warning signs that you should see in the patient before lumbar puncture? So that is that you have to examine for the signs of ICP, right? And what are the signs of ICP? Headache, papilledema, blurry vision, stuff like that. Whatever the signs are, you have to look for the signs, and because that could cause cerebellar tonsil herniation through foramen magnum. So we don't do lumbar tap in people, spinal tap in people who have increased ICP. So it's contraindicated in people having increased ICP. It's done on the level L3, L4, L4, L5, and we're good to go. Okay, so this is how I'm gonna teach. I'm gonna tell you guys questions of each slide. I'm just gonna be telling you guys that, okay, this is the question that would come. This is what you have to do. This is what you have to write. Okay, so this is a spine posture. You put the patient down in that way. You put the needle in. You guys know the drill. We talk about herniated disc. This is, okay, just give me 1 second. All right. Herniated disc. Obviously, they ask you what is the most common area of the herniation. So it's L4, L5, L5S1 in the lumbar region, right? In the cervical region, it's different. It's C5, C6, C6, C7, of usually younger people. Now, what causes herniation? Obviously, degenerative changes. This is the most common cause of herniation. All right. So this is the most common cause which they ask you. They do not ask you anything like apart from this. So now whenever we talk about herniation, what is that one thing that we have to keep in mind? Now in your world, they'll give you a question that, what, there is a patient, um, there's some sort of degeneration in the L4 vertebra. So Now, what disc would be herniated? So whenever you talk about a herniated root or the nerve or the disc or whatever, the nerve involved would usually be one number below, right? So if there is a herniation of L4, L5, the compressed root would always be L5. So you always go in descending order when you have to answer this particular question, right? Because a lot of people confuse it and say, oh, L5, L4, obviously, if L4 is degenerated and it shows in the MRI, then yes, L4 is the nerve which is being compressed. So that is the wrong answer. Always go one nerve down. All right. Um, Kyphosis, lordosis, scoliosis is pretty basic. Kyphosis is just exaggeration of thoracic curvature, usually due to osteoporosis. Lordosis is exaggeration of lumbar. So L4 lumbar, L4 lordosis, this is how you guys could probably remember it. The patient would come with pot belly, or we also call it as spondylo listhesis, but the common name is pot belly. So you would know that, okay, this is lordosis. Scoliosis is very complex. So scoliosis is lateral deviation or torsion. Um, could be caused by polio, leg length discrepancy, or hip disease, right? So these are the abnormal curvatures of spine. You just have to remember thoracic for kyphosis, L for lumbar, so L for lordosis, and then scoliosis is just lateral. So it's like things are going haywire over here, right? It's just lateral deviation. Okay. Um, Most common fracture of the upper limb is okay, this is extremely important. I cannot even skip this. I was thinking of skipping a couple slides, but this one, no. Okay, this is very important. They give you a question, right? A question stem, and they tell you that the humerus has been fractured. Now they ask you what site it has been fractured at, right? So there's three most common sites of humeral fractures. One is obviously the axillary, where the axillary nerve is, at the surgical neck, which is most important. Now, midshaft, the radial nerve is gone if it's a midshaft fracture. What they do is they tell you that, okay, this is a fracture of midshaft humerus. The case is here with you. Now, what nerve is associated with this fracture? Or they give you a scenario where they say, okay, the patient is here with midshaft radial fracture and wrist drop. All right, there you go. Boom. Now answer the question. So this is how you guys are gonna know. When you know the anatomy of each nerve, then you would be able to answer the questions. All right, then there's obviously brachial artery and median nerve at the supracondylar region. It's most commonly fractured in children, right? And then we have ulnar nerve at the medial epicondyle. Not that important. 1, 2, 3 are the most important ones. All right, so this is for the humerus. We move on, distal radial fraction. So a fracture of the distal radius. So it's Smith's fracture and Coley's fracture. Um, I'm sure you guys probably know about this, but let me just go through it pretty quick. So Smith's fracture results from a fall or a blow on the dorsal aspect of the flexed wrist. So, and it produces a ventral angulation of the wrist, right? Because obviously the blow is from the dorsal side, so the angulation would be ventral. It's always opposite, right? So what happens is that the fragment is interiorly displaced. However, in Coley's fracture, what happens is that it's due to extension. So it's the opposite of Smith's fracture. Um, what happened is that if you're having a fall and you try to ease down that fall by placing your outstretched hand on the floor, then Coley's fracture occurs, right? And obviously what happened is just for a second, just think about it, just go into that bubble and think about it, brainstorm that you're falling down, your wrist is outstretched. Now what happens is when there's an impact, the bone would go distally, right? So it's also known as dinner fork deformity. Um, it is often at ulnar styloid process, and the chip, like the part is avulsed, which means it's broken off. So it's extremely severe. It's more severe than Smith's fracture. Okay, I have questions. Okay, no. Okay, I thought there were questions. All right. Okay, we move on. Scaphoid fracture. Okay. So Colles fracture was when you have a fall, you have an outstretched hand to save yourself, and the impact is Colles fracture, which causes genital deformity. Now, in scaphoid fracture, you fall onto your palm, but your hand is abducted, right? So when your hand is abducted and you fall onto your palm, again, I want you guys to go into that bubble and brainstorm that what would happen. What happened is that obviously there would be impact on the lateral side because the hand was abducted, not adducted, right? So now it's on the lateral side. And the pain is obviously on the lateral side of the wrist. So there would be tenderness in the anatomic snuff box, which is the most alarming sign. They usually give this in New World. They tell you that there's tenderness in the snuff box. So what bone is most commonly fractured? The answer is scaphoid. And yes, one more important thing, that scaphoid fracture usually leads to AVN. Why? Because it is highly vascularly supplied bone, right? That's why hence it's the name is snuff box and stuff. Snuff box is the name because I'm sure all of you guys know, but snuff box as in you snuff, like you put those who do cocaine, they put it in their this part of the area and they snuff onto it. That's why it's also called a snuff box. It's highly vascularized, and that's why it goes into AVN. There is one more fracture in the human body, which is asked in UWorld, in which if there's a fracture of that particular bone, it goes into AVN. AVN develops. What is that part of the body? What is that bone of the body? If anyone knows the answer, write it in the comment box. Okay, boxer's fracture. Boxers, it usually, the name indicates, obviously by itself, it happens in boxers, obviously, while wrestling. Okay, let's see. We have, oh yes, femoral head. Good job. Good job. Proud of you. All right. So, boxer's fracture obviously helps in the boxers, right? Not that important, but just remember that metacarpals are fractured, second, third, metacarpals, and sometimes fourth and fifth. All right, pretty basic. They don't usually ask about it. Sits is important. You just have to know the name, right? This is the mnemonic to remember the name. So prospinatus and prospinatus, teres minor, and then we have oh my God, subscapularis. Okay. I was like, what is the fourth one? Okay, they just shoulder, they support the shoulder joint. They obviously reinforces the joint on all the sides, and when there is a tear um in one of these muscles. Okay, what is the most commonly teared rotator cuff muscle? Anyone who knows the answer, please write in the comment box. Comment box. Yes, please write it. All right, so abduction of the upper limb. Um, this is they don't usually ask this, but still, if you guys have to know, it's 0 to 15 degrees. So prospinatus is involved, 15 to 110, deltoid, and then as you go forward, then obviously your abdomen takes over, and trapezius, serratus anterior, obviously is involved. Okay. Um. Okay. So about this bursa, subacromium, the name suggests that it's beneath the acromion, the hooked acromion, and it's usually due to calcific supraspinatus tendinitis. And what happens is they ask in they give you they give you a question and they just ask you that, okay, this is what happened, and now the patient is having a painful abduction. So what do you think is going on? There's no fracture, there's nothing. The patient does not give you a history of fall, nothing at all. There's just a lump or a swelling on examination. So it just immediately clicks you that, oh, it could be subacromial bursitis since it's extremely painful. And when you touch the patient for examination, the patient will just, scream in pain. Okay, golfers and tennis. So how I remember this was GM, good morning. So golfers for medial, and then LT, lateral for tennis. And then you guys know the drill, right? You guys know that in what happens in lateral, what happens in lateral, medial. Okay. So I'm thinking that someone is texting in and I just keep on opening up the chat box. All right. So just remember the remember the mnemonic and you guys would be good to go. So in golfers, medial epicondylitis inflammation, and then in in tennis elbow, there is lateral epicondylitis. Okay, not important. Anastomosis is not important. We'll skip it. Cubital we'll skip it. Carpal tunnel. Okay. So anything pathological is extremely important. All these things that I'm skipping, you guys literally have to memorize it. Okay. Um, so yeah. Carpal tunnel, they obviously ask you the nerve which is involved. All of you guys know, I'm sure you guys know, you guys have to know that the median nerve is involved, right? And then obviously the patient will come to you in your world. They say that the patient comes to you, he or she usually happens in females. I don't know why, but she tells you that, okay, there's this paresthesias in my lateral 3.5 digits, and sensation is there, obviously, but just numbing and paresthesias, and it clicks you that okay, it could be carpal tunnel. The patient also could have history of RA or osteoarthritis. Okay. Ape-hand deformity is absent of opposition. So you see this picture, you see how the thumb is against the index finger. So this thing is lost in ape-hand deformity. Okay, not important. Uh, okay. Duck knee palsy, extremely important. So in duck knee palsy, there's paralysis of the muscles, and obviously C5, C6 is involved. Combination lesions of axillary, suprascapular, musculocutaneous nerve. The patient would present with something called waiter's tip hand. Now, if you guys again brainstorm and you guys see the tip hand, now how is it, right? I just make this picture in your head. You guys don't even have to read it. You guys do not have to read these points. You guys would just automatically say that the hand would be adducted, right? It would be medially rotated. The elbow would be extremely extended, and there would be loss of sensation in the lateral aspect because obviously C5, C6 were involved, right? Of the upper limb. So you guys don't have to do anything. You guys just have to go into that bubble of thinking and just think for a second that how is that waiter's tip hand? Like, why are they calling it waiter's tip hand? Okay. Clumsy paralysis. It's not that important, but yeah, in childbirth and also when you're like falling and you cling on to something to help you, kind of like deep, uh, just lessen the frequency or the impact of your fall. Then is when there's tearing of the brachial plexus, which is CAT1, which is the inferior trunk, right? Um, so yeah. It also happens, like I said, during it, it's a very common birth injury and thoracic outlet syndrome as well. In thoracic outlet syndrome, C8 and T1 usually shuts down. Okay, we did ape hand. Now uh this is claw hand, and we also talked about ape hand. So in ape hand, there was loss of opposition of the thumb and index finger. Now, in claw hand, the hand kind of forms into a claw, like into a tiger claw, and it just stays like that. Now, when there's clumsy paralysis, there is a combination of lesion of ulnar and median nerve because both the nerves are involved because what nerves are shutting down? C8T1. So that's kind of like, putting pressure on the ulnar and the median nerve, and that's why you get the claw hand and the ape hand as well, right? Okay. Not important, not important. Okay, we just talked about AVN of the femoral head. That I think that doctor just answered. So she was right about it. Usually due to osteoporosis in elderly women, obviously after menopause. Um, this is the only thing to remember. You guys don't have to remember anything else. You guys, I mean, if you guys want to go into the details, you guys could just, remember that okay, the medial circumflex femoral artery is involved, and that is why the AVN happens, but you don't have to go into that detail. Okay, unhappy triad. Usually happens in like vigorous players, athletics. What happened is that lateral side of the knee is struck, right? For instance, in a tackle game, in football tackle game. And obviously the tibial collateral ligament is most frequently torn. The unhappy triad is tibial collateral ligament, the medial meniscus. So just again, I would say again, just go into that brainstorming phase. You guys have to touch the lateral aspect of your knee and just boom, just hit on it with a punch. What happens? What happens? If you hit on the lateral side of the knee, what happens? Everything medially gets compromised, right? Because there is a blow from the lateral side. So now what's on the medial side? There's medial meniscus, there's ACL, there's TCL. So all of those things get compromised, right? So you just have to think in that bubble and you guys are good to go. Okay. So in uh okay, fibular collateral ligament or the lateral collateral ligament, it's not as important. Um, 1 second. Okay, we just did the unhappy triad. Okay, that's enough. Um, cruciate, nope. Okay, suprapatellar, how we saw this subacromial bursitis. This is suprapatellar. It is very common. They ask in the URL the position, the placement of the bursitis. So it is between the surface of the superficial surface of patella and the skin. So you have to just remember the prepatellar location, which I told you guys, and then there is one suprapatellar in which it is obviously the name suggests it is above, right? Above the patella. So yeah, you just have to remember the place of the bursitis. Uh, okay. As you can see this is the prepatellar right in front of the patella, and then we have this deep and superficial infrapatellar bursa. And then we also have the suprapatellar bursa, which is over there. Okay. Nope. Knee-jerk reflex, yes. Just one thing about the you have to remember the femoral nerve involvement in the patellar reflex, and then in the knee-jerk reflex it just tests the spinal nerve L2, L4. They don't usually ask this, but sometimes they do give these questions which are completely rectification, which are just completely memorization, right? Strictly memorization, and it has no concept involved whatsoever. So just for the safe side, you guys should know that this is the reflex, this is the nerve that we check. Okay. Okay, ankle sprains, not that important, but just know that the most commonly sprained ligament is the anterior talofibular ligament. That's it. The red part, that's all you have to remember, right? And yes, the most common ankle injuries are the sprains. Sprains are most commonly occurring, especially in the ankles. Okay, Pott's fracture. Pott's fracture is the dislocation of the ankle altogether, right? So what happened would be, again, just think about it, okay? Just think about what's happening. Now, if there's abduction of the foot, there's forced diversion of the foot. Now, what would happen? Again, there would be the medial ligament tear. There would be a fibula fracture if it's happening at a higher place. See, if it's happening at a higher place, then the fibula would get involved as well. If it's at the local, if it's downwards, then just the ligament, right? So there's two types, eversion, and then if there's inversion, there's forced inversion, there's adduction. Then what happens? Everything opposite. Now hit yourself, hit your ankle from the medial side. And what happens? The lateral thing gets compromised. So the lateral malleolus and the lateral ligament. So you guys don't have to memorize this. If such a question comes and if you guys have to answer what gets compromised, you guys just have to close your eyes, think for a second, and what would happen if I just hit myself, if I give myself a blow from this side, right? It's always the opposite ligament that gets hampered. It's always the opposite side of the body that gets hampered, right? Okay, just remember the nerve. Just remember the nerve. Ankle jerk, we check S1, S2. Just remember that. Nothing else. Um, Glute region, I don't usually go into the detail of it. I mean, but still, if you guys, just one important thing about the sciatica, If there's inflammation or spasm of the piriformis muscle, it could be very much similar to the pain of sciatica, and the patient would be confused as to what's going on. The patient would come to you, be like, okay, there's this pain, and the landmark would be the gluteal region. So you have to kind of like put your thought into it that it could be piriformis syndrome, and the presentation is very similar as to sciatica, right? And uh, supination of the hip joint relieves the pain, sort of. So yeah, but they don't usually ask this, so don't worry about it. Um, okay, what happens when there is injury to sciatic nerve? This is important. So foot drop and flail foot. They usually ask about flail foot, which is important. If you have flail foot, then there would be lack of both dorsiflexion and plantar flexion. So your foot is gone. It's like it's going straight to the ground as you're walking. It's slapping on the ground. There's no dorsiflexion. There's no plantar flexion. So it's like it's completely gone, right? If you have foot drop, then there is lack of only dorsiflexion, right? Still, you can have some amount of plantar flexion. Okay, I'm sure you guys know what dorsal is, what plantar is, what ventral is. I mean, if you guys don't, you guys can ask. I would be happy to explain. Don't shy because this is a crash course. Oh, you guys cannot ask basic questions. Trust me, if you guys have basic questions, I would be happy to answer, right? I'm just not going in the details because I have an understanding that you guys are probably um well versed about these terminologies. Okay. Superior gluteal nerve injury would lead to Trendelenburg gait. What happened is that the side which is contralateral to the nerve injury is affected, right? So in anatomy, if you see everything which happens on the side, like for instance, the right side, the left side gets affected, or the opposite side gets affected. So it's kind of like you always have to think about the opposite side first, right? Okay. For instance, if a patient comes to you, they ask you in the real world that there's a patient who comes to you with left superior gluteal nerve injury. So now, you ask the patient to walk in your clinic. Now, which side of the body would dip, right? So your answer would be the right pelvis, right? So it would always be the opposite side. Um, just remember that. Okay, no, nope. Femoral hernia. Okay, let's just do a little bit of femoral hernia. Femoral hernia is very important. They don't usually ask it like that, but I mean, come on, just a little bit. Commonly occurs in female. Okay, less common than inguinal hernia, obviously. Commonly occurs in old age people. It's dangerous because the herniated sac could become strangulated, right? Yeah, that's about it in femoral hernia. Uh, 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 um, no, this is all memorization. Um, I mean, okay, so if there is an injury to the tibial nerve, there would be inability to stand on toes. There would be loss of plantar flexion, right? So usually the muscle which is involved is gastrocnemius. They don't usually ask you this question, but just for the sake of it, just memorize the loss of plantar flexion and inability to stand on toes, because obviously if you cannot stand on toes, that is basically your loss of plantar flexion. Uh, okay. Fibular neck fracture could cause foot drop. This is an important question from the UL perspective because they do ask you that, okay, when there is a fracture of the fibular neck, what nerve is involved? So it's common peroneal nerve. It also asks you the prognosis, what happens, what is the diagnostic criteria, how would the patient present to you? So if the common peroneal nerve is injured, the patient would present to you with wrist drop. Okay. Um, okay, this is pretty basic. Oh no. I've never seen questions from diaphragm, but if you guys do want to go through it, you guys can. Um, it's pretty basic, pretty easy. Um, okay, this is important. The auscultation of heart valves. We are going to go in the detail when we do the cardiology. Um, I I don't know if I'm gonna do it or Dr. Taha is gonna do it, but this is just the like the overview of it, right? The auscultation of heart valves. We can auscultate it at, there's aortic valve, there's tricuspid valve, there's pulmonary valve, there's mitral valve. So these are all the positions of the auscultation that you guys can do. They don't usually ask this, but obviously you need to have that sort of understanding as to at which valve you get which murmur, and we're going to talk about it all in detail. Um, Blood supplies, they don't usually ask. Um, they're more interested in the pathology. So yeah. Okay, aspiration of foreign bodies, they do ask this, is very important. Aspiration of foreign bodies is usually in the right primary bronchus, which they do ask in the URL that, or what bronchi is, more likely to get affected. So it's because obviously the right bronchi is shorter than the left one. It's narrower, so that's why it's always the one which gets hampered, right? It is past the foreign body, is passed into the middle lower and middle or lower lobe of the bronchi. Now I want you guys to just think about it. If the patient is laying down, then you will see the foreign body usually in the posterior basal segment, okay, of the right inferior lobe. So okay, this is a very big thing to remember. So I remembered it as just the posterior, the option which says posterior or basal, right? So posterior basal, posterior inferior, posterior basal. Any option that says that, if like the patient is supine. But if the patient is standing, obviously it would be in the inferior lobe whatsoever, right? Because obviously the effect of gravity and you would see it down in the inferior lobe. But if the patient is laying down, then you would see the body in the posterior inferior, posterior basal, whatever that option is. Okay, so that's what you guys have to remember. All right, pneumonia is very important. Um, I just want to tell you guys that we're going to do each system individually when we do the systems, but since it's a gross anatomy intro, so we're just gonna go through everything, right? Pneumonia, obviously you guys know that there's inflammation of the lungs. It could be because of bacterial pathology, viral, fungal. What you see in the chest x-ray is opacity. Opacity is anything that is white. So, right? So this white thing is opacity. This is opaque. This is transparent, the black shadow. This is opaque. So whenever there's opacity, your mind would go into pneumonia because they show you the x-rays in your world, right? And in the like your final examination as well. So whenever you see opacity, number one thing should be, okay, this is bad. This is pneumonia. And then you go into the pathology of it, right? Okay, this is that one thing that I used to have a lot of problem with, opacity, transparency, stuff like that. And then finally it all started to make sense when I learned the basic, right? So that's what you have to learn. Now they're going to show you the x-ray. They're going to tell you the patient comes to you. The patient is complaining of mucus, productive cough, hemoptysis, which is us. It should ring a bell. Okay, the patient is old, the patient has smoking history, the patient is coughing a lot, stuff like that. Now, when you did the x-ray, you see that they just show you the x-ray. Now, what happens is you just the history of the patient, the fact that he's old, the fact that it's a male, the fact that there's hemoptysis, and then you see this white ball sort of thing in the x-ray. Weight loss, age, everything. So you know that, okay, this is a tumor, right? So that's how you guys are gonna diagnose. Um, okay. Mm, mm, mm. These notes would be uploaded in the Med Exam Expert website, so don't worry about it. Um you guys will be able to go through all of them. Okay, so these are the group moderators. in a louder volume because Pakistani and Indian students face difficulty understanding the accent. Okay, I'm sorry if you guys are having difficulty in understanding the accent. But okay, you guys can tell me if you guys want me to speak in a specific manner, okay? If you think my pace is too much, just type it in. Because the thing is that we don't have time. Okay, so we're going to talk about indirect inguinal hernia. So now this is the most common form of hernia. All right. It usually happens like you would get a case of a boy, a young boy, 0 to 3 years old, and the boy would be presented with the hernia, like he would be crying. There would be obviously um, swelling, and then you would know that, okay, this is a hernia. So there's two types, indirect and direct. Direct usually happens in older people, and indirect happens in the in younger. So now what they ask you is the relationship of the hernia to the inferior epigastric vessel. All right. So whenever we talk about the indirect inguinal hernia, it's always lateral to the inferior epigastric vessel, right? So the mnemonic to remember this is IL. Okay, so indirect would always be lateral. ठीक है, IL. And then direct would always be medial to the inferior epigastric vessel. Mnemonic is DM. DM as in direct message, right? So DM and IL. That's it. Nothing else to remember. If you guys remember these two things, you guys are good to go. So they ask this in your world that indirect hernia what would be the route? So it's always lateral to the inferior epigastric vessel, and the direct one would be medial. If you guys know this, you guys are good to go, trust me. Right? Okay, we already talked about the direct inguinal. It comes out from the Hazelbatch triangle and disease of old men. Like I told you guys, it's common in old men as compared to youngsters. And I told you guys about the route as well. Medial. Okay? So DM and then IL. Okay, these are the mnemonics. Write it down if you guys have a pen and paper. It would help you guys later on when you guys revise, right before the exam. Okay, nothing to remember in this, just the portal triad and the contents of portal triad. So the portal triad consists of bile duct, portal vein, and proper hepatic artery. So one artery, one vein, and then obviously the bile duct, right? This is what you have to remember, just the portal triad, because later on, when we study GID, there is going to be so much of portal triad, you guys are going to get tired of it. So the contents, all right? Okay, Winslow Foreman, not important. Douglas, not important. No. Okay, this is all memorization. I want you guys to go through these notes tonight, before you guys go to sleep and just see what is, what is something that you guys think should be memorized, right? So just go, it would hardly take 1 hour. So whatever we study, if you guys study it later on, it would help you guys so much. Okay, CDH, very important. Congenital diaphragmatic hernia, usually you're able to see such sort of a problem at the 20th week anatomy scan, but just in case if it's missed out, then the presentation would be the baby would obviously, you would see it in the infants. They would ask you the route, right? They would ask you that where would the defect be? So the answer is posterolateral, all right? Or it's also known as foramen of Bocadelic, but the options would be posterolateral defect. So most commonly it's posterolateral, and the diaphragm, like there would be a hole and the intestine would be protruding through it, and the baby would be born with serious signs of vomiting, and you would just know that, okay, there's something not adding up. Okay, so congenital diaphragmatic hernia obviously is common in the infants, but sliding hiatal hernia is usually common in the, middle-aged people. Now, like the name suggests, that a part of the intestine would obviously slide, right? It would slide up, and then the patient would just present to you with what? If it's sliding up, the patient would present you with GERD symptoms, right? There would be reflux, there would be acid reflux, there would be cough, there would be dyspnea, there would be sleep apnea. The patient would say that, okay, doctor, you know what? I'm not able to sleep at night. I have this GERD going on. There's something going on with me. What you do is you do a barium swallow, and then is how you examine the sliding hernia. Okay. Meckel's diverticulum, that important. Mm, they don't usually ask from appendicitis because everyone knows about McBurney's. Everyone knows that it's pretty basic. Um, okay. We still have so many slides to go through, and we barely have time. So I'm gonna skip all the arteries and nerves because obviously you guys would memorize it. If you guys have any question, you guys can hit me up on the WhatsApp group. All right. And don't worry, because all of these things that we're studying right now, you guys would have to study about them all over again in the systematic manner in each system. So don't worry about it. You guys are gonna go through all of it. Okay? Um, okay. Well, um, all right. Head of pancreas jaundice. This is important. Not the jaundice, the cancer. Okay. So most commonly, if you have pancreatic cancer, it occurs in the head of the pancreas. The patient will usually come with history of saying that, oh, I've been alcoholic for this many years. The patient would come with, um, visible signs of jaundice. You will run the test and you would find out that, okay, this is the cancer of the head of pancreas. So the jaundice would be of obstructive type. It is not associated with pain or fever. So that's how it rings a bell in your head that, okay, this could be something which is not inflammatory, which is not bacterial, it's not infectious, it is something cancerous, right? So like I said, hepatitis also causes jaundice, but that is associated with fever, right? So you guys would know. Now, uh, about that, just anatomy of pancreas, they don't usually ask. From the anatomy, peritoneal connections, no. Um, okay. Okay, this is very important. Nephrolithiasis is extremely important. Their most favorite stones are oxalate stones. All right, so in the USMLE question pool, you would get so many questions of oxalate stones. They are their ultimate favorites, right? So you have to know everything about oxalate stones. They are their topmost favorite, and they're formed from the oxalate, NH3, ammonia, all of that stuff. When you study the nephrology system, you obviously would study in detail about these stones. Um, Most commonly, they causes urethral obstruction, and then the patient would present with colicky pain. The patient would say that, okay, this pain, doctor, I'm having this pain usually in the left side, and it's remitting and relapsing in nature. That is the history that the patient would provide you with. The patient would say that there's pain when I micturate. Sometimes the patient would present with bloody micturation. Sometimes the patient would present with nephrolithiasis or, fever. In nephrolithiasis, there would be fever, is what I was trying to say. Um, so yeah. Okay, so staghorn calculi, um, once again is one of their favorites. They are composed of magnesium ammonium phosphate. This composition is very important. They do ask it in the U World that what is a staghorn calculi composed of? It's composed of this thing, magnesium ammonium phosphate. The pH is high. It's basic. So because whenever there is ammonia, the pH would be high, right? Okay. And also the pH is high because of recurrent UTI is happening. There's infection with microorganisms like Proteus mirabilis. They do ask about Proteus mirabilis as well in UWorld. They would either give you the infection, they would just either say that the patient is coming repeatedly to you with recurrent UTIs, And we just found out that there is a renal stone. Now, what is the composition of the renal stone? Because obviously they don't like asking easy questions, they like asking complex questions. So they would just ask you the pH or the composition. So this is very important to know. Okay. Varicocele, not important. Okay. Um, okay, for some reason, ureter is one of the favorite parts of the USMLE question pool. They love to question about ureter. I don't know why, but it's just, it's something that they do like to question about. So, there's three places in which there's the most commonly constricted part of the ureter. So one is when the ureter crosses the pelvic brim, right? Which is near the bifurcation of common iliac artery, right? And then in male, there would be the position number two, which is crossed superiorly by ductus deferens right before entering into the bladder. And then in female, it would be crossed anteriorly and superiorly by the uterine artery, right? Which goes in the base of the broad ligament. So most commonly, the ureter is also damaged by hysterectomy. If a woman is undergoing hysterectomy or surgical repair of a prolapsed uterus, this is one of the most commonly uh, done mistake by the surgeons, that the ureter is damaged because it goes so much closer to the uterine artery, right? So the chances of it getting damaged are pretty high. Okay. Um, Okay, let's do talk about prostate. We cannot skip prostate. Okay. So when we talk about prostatic tumors, you know that they usually begin in the posterior lobe of the gland, right? So in early stages, the patient would be completely asymptomatic, and then when the stages would, kind of progress, the patient would present with signs, right? What would be the signs? Signs would be burning micturition, difficulty in um, initiating micturition, or right after the patient is done micturating, there's some sort of irritation down there or burning. Okay. The most commonly metastasized bone due to prostatic cancer is the vertebrae and then the brain. They usually ask this question. Okay. Because obviously the prostatic venous plexus has connections with the vertebral venous plexus. So that's why it spreads directly to the vertebral column. Okay. Now, when we talk about BPH, whenever there's a question of prostatic carcinoma, it should ring a bell in your head that, okay, this is the most commonly the posterior lobe of the prostate. But whenever there is a question of BPH, that involves the median lobe. Okay. And because of that, there would be urethral obstruction. Now, you don't have to memorize this. If there's a BPH, it's constricting the urethra. It should already tell you that what's going to happen. If urethra is being constricted, what would happen? Obviously, there would be dysuria, there would be pain, there would be always an urgency to void, right? And then there would be increased desire to void. So just think of all these things. And the patient will come to you with all of these symptoms. They're like, okay, he's 60. He's telling me that he has urgency to void. He's telling me that he has dysuria. I just did the complete urine culture. Everything comes out to be normal. Then you should be like, okay, I think this is BPH, right? So then you do the prostatic examination, the which we call DRE. Oh, so yeah. Prostatectomy, we don't worry about it that much. Okay. So spongy part and the membranous part of the urethra is important in the pathological aspect, which you would study obviously in the nephro. I think whenever you guys have a lecture. Um, So yeah, okay. We can do a little bit of embryology as well. Cryptorchism is a disease, is a condition in which it's you have a condition of undescended testes. Okay, it's a disease, it's a condition. I'm sorry for calling it a disease. It's a condition in which the testes fail to descend. Okay, and usually what happens is that it does descend within 3 months of birth, but sometimes it does not because it gets entrapped in the inguinal canal, and then it's malignant. Obviously, it does go into a malignant transformation, so it's very important to do the surgery and take it out and, like evacuate it. Um, so yeah, in case of cryptorchism, spermatogenesis is arrested, obviously. So it depends if it's unilateral or bilateral. It goes deep into the detail. If it's unilateral, then obviously spermatogenesis will not be arrested. It would still take place from the other testes. If it's bilateral, then yes, it's a pretty um serious condition, right? In both the cases, even if it's unilateral or bilateral, you have to take the one out which has not been descended because it could convert into something malignant. Okay. All right. Mm, there's so much of arterial supply and so much of nerve supply that it just, I don't know why they give so much of it because, okay, hematoma, important, very important. So I always used to have a problem with memorizing the subdural, epidural hematoma. So what I did was I understood the terminologies, right? Epi means up. Dura is obviously the dura mater. So anything which is happening above the dura mater is epidural hematoma, right? So now it's pretty basic to remember that, okay, it would be above the dura surface, and the artery most commonly involved it would be the middle meningeal artery, right? So it's just, that, okay, epi is above. Right? Now, one more important thing is they usually give you the MRI and they show you that we have a biconvex pattern, right, on the CT or the MRI, more commonly the CT. So the biconvex pattern is always the epidural hematoma, right? Okay, you have to remember this. Biconvex and epi. Cavernous sinus infection is important, which you guys would learn in neuro, but let's talk about it while we're here. Um, you have to remember the structures that pass through the sinus. Okay. You cannot, we cannot avoid this. So internal carotid artery, abducens nerve, and then on the lateral wall would be oculomotor nerve and the trochlear nerve. So this is important. You have to memorize it. Okay. Um, Ophthalmic vein, no. Layers of scalp, nope. Bell's palsy is due to cranial nerve 7. Um, Destruction, pretty basic. So you guys are going to do this in neuroanatomy in the neurology section, but still TMJ. Okay, we were going to still talk about a little bit, okay? Because this is a gross anatomy intro, so we're going to talk about a little bit of it. Okay, so TMJ is temporomandibular junction. Now they usually ask you either the names of the muscle, because I've seen a straightforward question which they just asked you and you were that, okay, what are the 4 muscles? Or they ask you the innervation. All right, so it's just either or. Um, the muscles are very simple to remember. The temporalis, which is involved in elevation and retraction, masseter, medial pterygoid, and lateral pterygoid. Okay, lateral pterygoid is important. You guys have to remember this. Sometimes they only ask about lateral pterygoid, that, okay, this helps in what? So protrusion of the jaw. Okay. All of them are doing elevation, just the lateral pterygoid is doing protrusion. So you have to remember this is very important. Um, okay, no, gag reflex, no. So you have to remember that in gag reflex, cranial nerve, the vagus nerve is involved, the efferent limb we're talking about, and then efferent limb, cranial nerve 9 is involved, glossopharyngeal. So yeah, this is something that you have to remember. All of the slides that we're not doing does not mean that you guys don't have to read about it. Please do read about it, such as these things. Memorize these things because they are important. And then when we will be doing the systems individually, we will study about them in more definitive manner. Okay. DNP is very important. Trochlear nerve palsy. We're going to talk about it a little bit before you guys do it in the neuro section. So what happens is in trochlear nerve palsy is that there is paralysis of the superior oblique. You have to remember this superior oblique muscle, right? So now if there is an impairment of the superior oblique muscle, what would happen to the eyeball? The eyeball would not be able to turn inferior-medially, right? So the person would always be looking superior laterally. Like the normal eye would be normal. For instance, this eye is normal. This eye, obviously, you can see that the patient, this eyeball is laterally deviated towards the superior side, right? So the patient would come to you with signs of diplopia, which is double vision. Then this is, oh my God, this is so important. The patient would come and would tell you that, doctor, when I go down the stairs, I look down. So it's called the chin deviation also. This sign is so important in evaluating that, okay, this is a case of TNB. All right. So why does the patient do it? Because the person compensates for diplopia. Because obviously there's double vision, right? So the patient would tilt his or her chin in a way that the patient would be using his or her normal eye more to see the stairs when they walk down because obviously they don't want to fall. And because of that head movement, it's a typical sign of TNB. Okay. I hope this is clear because this is a very important concept and they ask about it a lot, a lot. Um, okay. Horner syndrome, let's just quickly go through the signs of Horner syndrome because they're very important. A person who comes here with Horner syndrome would have meiosis, which is the constriction of pupil. And what is the dilation of pupil called? It's called mydriasis, right? So meiosis, then there would be ptosis, which is the drooping of the eyelid. There would be vasodilation, and there would be absence of sweating, which is anhidrosis. So these are the signs of Horner syndrome, which you have to memorize. Okay. Um, okay, this is important. Median cervical cyst is important. So this is usually, you would see it in toddlers or kids. It's painless midline mass. Okay. And it does move during swallowing. This is what differentiates it from the thyroglossal cyst. And it's a remnant of thyroglossal canal. What we do is to treat it, we just do the surgical excision. What you have to remember is that it moves. It moves during swallowing and it's painless. There is no pain. Okay, this is all you have to remember. Okay. Um, okay, what else we need to do? Okay, I think we are done with gross anatomy. If there is any question, you guys can write it down in the comment box and I would be happy to answer. We're gonna start genetics. I know you guys would be drained out by now, and there's still so many things to go through, but okay. In genetics, I'm not gonna scare you guys out. We're not gonna go deep into the heterozygous, homozygous, and all those Mendelian laws and stuff. We're gonna do that when we do the U world, right? So I don't want to hamper you with that and with the, with all those questions because they're extremely scary. What we're gonna do in today's session, we're just gonna go through the definitions because that is what is extremely important. Okay, so once you know what is that, what is anticipation, for instance, what is dominance, what is codominance, what is heterozygosity, what is homozygosity, then you guys are good to solve the questions, right? So when next time we do the your world questions, if you guys focus in today's session and if you guys go through the genetics, the, like the basic genetics, trust me, you guys are good to go. Okay, so now take a break for 5 minutes. You guys grab a glass of water. Um, chill out for 5 minutes. I'm giving you guys a 5 minute break. I'll be seeing you guys in the next 5 minutes, and then we're gonna start genetics. So yeah, you guys have 5 minutes. I'll be seeing you guys in 5 minutes. All right, guys, welcome back to this session. We would be doing genetics now. Okay, so genetics, we're gonna do the basic genetics in the time frame that we have remaining. If you guys have any questions in regards to the intro that I gave, in regards to gross anatomy, you guys can ask me right away. Okay, and then or if you guys, just write it down in the chat box. Um, give me 1 second, I'll be sharing my screen with you guys. Okay, so genetics, we would be doing straight from first aid because there's no other resource for genetics, which I think is more applicable than first aid itself. Okay. So there's one more thing that I want to add. If you guys really want to go through some high yield genetics, which is very important, then go through Mehelman PDF. You would get it on the website. It's for free. You can download it. It has extremely good high yield topics for genetics. So you guys can go through that. It's called Mehelman. I'm sure all of you guys, like most of you guys know about it. If you guys don't, then check it out. It's really good. I was going to add some questions from Mehelman in this presentation, but I would be doing it in the next session for sure when we're gonna do the UWorld questions. Okay, so it's pretty basic, pretty high yield. It only covers the important stuff that is required to know for the exam. Apart from that, okay, so first Mehelman, I wanted to talk about Mehelman. Then there are some people who also study Kaplan genetics notes. If that works for you, great. A Mehelman really worked for me, and first aid worked for me. So basically, I only saw like 5 to 6 questions of genetics in my exam. So it depends what pool you're getting, what questions you're getting. You could get a lot of questions, who knows, or maybe you could get like a couple, just 5 or 6 questions. So it's not that important, but we cannot skip it. So we do usually go through just the terminologies, which are important. Okay, so we're gonna do the terminologies, and I would not drag you guys to the heterozygous, homozygous stuff because that requires a lot of practice. So we're gonna do, and I'm gonna write it down for you because I know the spelling is kind of tricky. Um, I don't know, how do I? Okay, so I just sent it to you guys. Okay. So this is the PDF that you guys have to follow for genetics. If you guys want to. Totally your call, or else you guys can just go through first day. There's roughly 5 to 6 questions, so don't worry about it too much. But you guys should know the basic terminologies. Right, so in this session, we're only going to go through the basic terminologies, and in the next session, we will be going through all those URL questions, which I'm sure they drive you crazy. Okay, so let's talk about codominance first. Let's start with codominance. Okay, one more thing. I was talking about the Kaplan notes, the genetics, the notes for by Kaplan. So if you guys want to do that, you guys could, but it's extremely detailed. So I think it takes a lot of your time and energy. So I would just recommend for you guys to stick to Mehlman and First Aid. Okay. So let's start with codominance. Okay, co means obviously both the genes are involved. So in codominance, both alleles they contribute to the phenotype. Okay, so for instance, we have the example is blood groups AB or alpha-1 antitrypsin deficiency. In HLA groups, we see the type, the the term codominance, in which both alleles are coexisting at one single time. Okay, now in variable expressivity, as you can know from the terminology, that variable means the patients with same genotype would have varying phenotypes. Okay, genotype is the genetic material, to be very precise, and the phenotype is the material which is not transferred by the genes. Okay, it's the physical traits most commonly. So if you guys want to write it down, you guys can write it down. Okay, so variable expressivity, there would be same genotype, but there would be varying phenotypes. Okay, for instance, I have two patients of neurofibromatosis in my clinic, but they're both presenting with different disease severity, right? So they're both expressing what? They're expressing variable expressivity. Now, from the exam point of view, I'm just going to tell you guys one thing. This right side of the table is your guys' go-to. Okay, if you guys remember this, you guys don't even have to worry about this. So the cases in your world would be from this table, from the example. For instance, NFT type, we just talked about NFT1, NFT2. These patients, they come to you with the same disease, but different intensity. There's two patients coming to my clinic with, some other sort of disease. The disease is same, but they're expressing it in a different manner. So obviously, what are they? What is going on with them? What is the terminology we use for them? Variable expressivity. So you just have to remember this. For instance, incomplete penetrance, not all the disease, not all the individuals with the disease show the disease. For instance, they would have the penetrance, but it's so incomplete that they would not show the disease. For instance, BRCA1 gene mutation, it does not always result in breast or ovarian cancer. A patient would have BRCA1 gene mutation, but the patient would not present with breast cancer or the ovarian cancer. So that's incomplete penetrance. Right now in pleiotropy, pleo means many. So one gene, when it contributes to many phenotypic effects, that's pleiotropy. Once again, they would give you the example of PKU, right? So in your world, it says that a patient comes to your clinic. The patient has been diagnosed with PKU. The patient manifests with light skin. The patient has musty body odor. The patient has intellectual disability. So what is the genetic terminology you would use to describe the disease that the patient has? The answer would be, they would give you options. Number one, codominance; B, variable expressivity; 3, incomplete penetrance; 4, anticipation; 5, pleiotropy. Okay, A, B, C, D, E. You have to pick pleiotropy. So these, like I said, these things would be the question in the U world, and these things would be the answer, because it's never so easy that they give you this. Like, it's never in USMLE, it's never going to be a fact that they give you pleiotropy and they ask you the definition. There's 4 definitions and you have to pick one. No, this is not that. This is not MCQ. This is a BCQ. You have to choose the best answer, right? So yeah. Okay, we talk about anticipation. Anticipation is just increased severity. Okay, you just have to know it from the name. Anticipate. When you anticipate something, it's the severity of that thing, right? For instance, a patient comes to you with Huntington disease. Now his son has come to you with Huntington disease as well. But the severity of the disease is so high in the son as compared to the father. So what is that? What is that thing showing to you? It's showing you anticipation of the disease. This is a very commonly asked question in your world. Very commonly. Okay, so they love asking about anticipation. They love asking about incomplete penetrance. These are some of the genetic terminologies which are asked over and over again. Okay. Loss of heterozygosity would be the patient develops a mutation in a tumor suppressor gene, right? So any wild type of allele should be deleted or mutated before the cancer develops. For instance, in retinoblastoma, we have the two-hit hypothesis. And the two-hit hypothesis in Lynch syndrome and Lee-Fraumeni syndrome. So it's just that so there's two genes, right? A tumor suppressor gene and a oncogenic gene. So if there is a mutation in a tumor suppressor gene, then the other gene takes over, which is not a good gene, it's a bad gene. In epistasis, we talk about it happens if the allele of one gene affects the phenotypic. So now, when we talk about whenever there is the word phenotype, you know that this means physical. This is not genetic. Genotype was genetic. Phenotype is physical. When epistasis, there's the allele of one gene affects the phenotypic expression of the alleles in another gene. For instance, albinism and alopecia. So all of you guys know albinism is whitening of the skin, alopecia is balding. So in some men or in some women, alopecia is to some extent, right? But in some men, alopecia is to an extent where they go completely bald, right? So that is epistasis. That is, there is alteration of genes in a way that the phenotype of the gene is disturbed, which is the physical, the physical aspect. In some patients, their albinism, it starts from the face, it goes to the hands, and it stops. It halts. But in some patients, there's no halting. The whole body goes under albinism. So now this type of thing in which the phenotypic expression is altered is epistasis. Aneuploidy, obviously, the name suggests abnormal. Obviously, aneuploidy, abnormal number of chromosomes. This came in my exam. The question was simple Down syndrome scenario. They gave a Down syndrome scenario and they asked me that what is the genetic terminology that you would use to show what's happening with the chromosomes. So the answer was aneuploidy. Sometimes the answer is non-disjunction during mitosis or meiosis. This is also the answer. They give you the whole scenario of Down syndrome or Turner syndrome, and they tell you that, okay, aneuploidy is taking place, but this is caused due to what? Misjunction, frameshift mutation, non-disjunction, deletion, and then you have to pick non-disjunction during either mitosis or meiosis. Okay, so if you guys are done with the genetic terms and if you guys know what they mean, trust me, you guys are good to go. You guys are like, it's a green light for me for genetics. So these terminologies are extremely important. If you guys have any questions about these terminologies, please go ahead and ask. Hardy-Weinberg principle, they never ask this, but we're still going to do these genetic terminologies, which we were on right now. How to differentiate from variable expressivity, is that your question that you're trying to ask? I think so. Okay. So variable expressivity is something in which the patient would come to you. The patient would come to you and the patient would say that we have the same genotype. Okay, for instance, the patient would come to you, for instance, let's take a less severe disease. Two patients come to you and they say that we have this condition, which is, a Bell's palsy, for instance, Bell's palsy. Now, both of them have Bell's palsy, but in one patient, the severity is little lessened as to the other patient. Okay, the side of the face is little less deviated. There's little less drooping of eyelid. There's little less problem in smiling. The patient could frown, but the other patient, there's complete loss of frowning, there's complete loss of whistling or blowing, there is complete deviation, there is complete loss of any expression. So the intensity is increased, but both of them has bells, right? So that is variable expressivity. Both the patients have same disease, but just the expression of the disease is different. Okay. All right. Okay, I hope this is that explains it. Um okay. Let's start with dominant negative mutation. So dominant negative mutation would always exert a dominant effect, okay, in which a heterozygote produces a non-functional altered protein that also prevents the normal gene product from functioning. So such a protein would be formed by the heterozygote such a non-functional altered protein that it would also go and distort the normal gene from producing the functioning. You know what I'm saying? So, for example, let's do the example and then it will probably become clear to you guys. If there's a single mutated p53 tumor suppressor gene, okay, so p53 tumor suppressor gene is a good gene. Always remember that. You guys can write over here so that you guys remember. So if there's mutation in this gene, then obviously it would not be suppressing tumor. Now it's a bad gene. Now what happens is that this bad gene would also go and tell the good gene to stop functioning, right? So this is the dominant negative mutation. For instance, if you stay in company of bad people, you kind of become bad too, to some extent. So just remember that, just apply that concept over here and you would be fine. So that is a dominant negative mutation. Okay. Linkage disequilibrium is not usually asked, so we don't usually waste our energy on it. Mosaicism is important. So we're going to do this. There's two types, somatic and germline. Somatic, obviously, you know by the name, soma in the cells. So mutation arises from the mitotic errors. Whenever soma is involved, you know that there is mitotic error, right? And then germline is the gonadal mosaicism. So it could only occur whenever there is the word germline, you know that it could only occur either in ova or in sperm. There's no other way of it occurring, right? So you always suspect the gonadal disease. Now, uh this is very important. Cafe au lait, cafe au lait, no, a meconial bright syndrome. This is extremely important. They give you a case of a patient, and this is the word that they use, which is very important, ragged edges. Always remember this. The patient would present to you with unilateral cafe au lait spot. This is the unilateral cafe au lait spots are just macules, dark brown macules, which we call cafe au lait spots. They're also present in neurofibromatosis, but in NFT, they're widespread. Okay, but in meconial bright syndrome, they're in a pattern. You know what I'm saying? So, like, that's how you distinguish them. So, they're in a pattern with ragged edges. You see the edges? They're not distinctive, they're ragged. So the patient who comes to you with ragged edges, with cafe au lait spots, they usually ask you what is going on with the patient. You say mosaicism. Sometimes they ask you about the mosaicism. Sometimes they ask you directly about the disease. You say meconial bright syndrome. It's very important. It's very commonly asked in your world. Um, so you have to remember this. Apart from that, there's nothing else to remember. Just remember the ragged edges. This word, whenever it comes, it has to ring a bell that it's either meconial bright syndrome. And what happens in meconial bright syndrome? Mosaicism. Okay. Um, Locus heterogeneity is there is a mutation at different loci, but it results in the same disease. Okay. So now, for instance, there's locus, right? Between the exons, there's loci. So there is mutation occurring at different loci, but all of those mutations are causing albinism, or they're causing retinitis pigmentosa, or they're causing familial hypercholesterolemia. So it doesn't matter what the location is, but the disease is the same. Okay. Now in allelic heterogeneity, there's different mutation in the same. Now the locus is the same. The position is the same. The placement is the same, but the mutations are different. Okay. So frame shift is also happening. Deletion is also happening. Non-disjunction is also happening, but they're all happening at the same spot. While in the locus heterogeneity, different loci were getting hampered. Okay. So the example of allelic heterogeneity would be beta thalassemia, which is the only example of allelic heterogeneity present in first aid. So we only have to remember this one example. They usually ask this. They don't usually ask questions from locus heterogeneity, but they do ask what's happening in beta thalassemia. So the answer would be allelic heterogeneity. Okay. Heteroplasmy is important. So in hetero means different. Okay. So in heteroplasmy, there's DNA from both normal and mutated mitochondrial DNA. Okay. So both the DNAs are present in a child. Now, we all know that the mitochondrial DNA is only passed from a mother to her children, right? So, whenever we talk about heteroplasmy, we only think about, okay, the mom has inherited this condition to the baby. So, hetero means different. So, you know that, okay, the normal chromosome would be there as well, and the mutated gene would be there as well. Okay. Uniparental disomy is very important. Um, so in uniparental disomy, uni means one, parental obviously a parent. So now the baby receives two copies of chromosome from one parent and no copy from the other parent. For instance, there's a child who's born. He received two copies from dad, but nothing from the mom. Okay, so this there is a, it's of two types. It's either heterodisomy. In heterodisomy, there is a meiosis one error. They usually don't ask this, but just for the safe side, isodisomy indicates a meiosis type 2 error. Okay, so just remember the number of eyes. In heterodisomy, there's one eye, so meiosis 1. In isodisomy, there's two eyes, so meiosis type 2 error. Okay, um, okay. We're gonna do one more thing about genetics. We're not doing Hardy-Weinberg principle. It is not important at all. We're doing this, disorders of imprinting, which is very important. Okay, extremely important. Okay, whenever you talk about methylation, whenever there's a word methylation in genetics, you know that, okay, methylation means silenced, mutated. Okay, so whenever there's a word of methylation, mutated or silenced. So in imprinting, one genetic copy is methylated and only one genetic copy is expressed. Okay, so the expressed copy could either be mutated, it could be deleted, it could be not expressed, it could be whatever. But now we have only one copy. Okay, so there's two types of disorders of imprinting. One is Prader-Willi syndrome, another is Angelman syndrome. Okay, I remembered it as the mnemonic, which is very common for it. So in Prader-Willi, P for Prader and P for paternal. So in Prader-Willi, paternal allele would be deleted. Okay. Now paternal allele is deleted and maternally derived genes are silenced. So they are of no use as well. Right? And paternal allele is deleted at all. So now signs and symptoms would be, just imagine the paternal, like the usually the paternal side, okay? Or the father or the grandfather. So the sign would be obesity, intellectual disability, hyperphagia, hypogonadism, hypotonia. It would be the chromosome. You have to memorize this, chromosome 15 of paternal origin. Okay, this is the mnemonic, which is POP. Prader-Willi, obesity, paternal allele is deleted. So you know that paternal allele is deleted and maternally derived genes are silenced in Prader-Willi syndrome. Now, what they do is they're so smart in USMLE. They will not ask you that in Prader-Willi, what allele would be deleted. They will not ask you this question because they know it's so common. Everyone knows the mnemonic POP. Everyone has memorized, oh, Prader-Willi means paternal is deleted. They all know. So they're very smart. They will not ask you this question. What will they ask you? What genes are silenced in Prader-Willi syndrome? That is the question they ask you. And for a fraction of a second, you're like, silenced paternal genes. But no, the answer is maternally derived genes are silenced. Okay, because whenever the human mind is sort of like a thing in which whenever you hear the word Prader-Willi, you're gonna be like, oh, paternal. But no, just read the question carefully because they never ask the simple question. This was a question in my exam. They asked me that what genes are silenced in Prader-Willi syndrome? And the answer was maternally derived. Okay, so yeah, remember that. It's a very tricky question, but that's how they ask the question. Now, when we talk about Angelman, you see the mnemonic is M for man and then M for maternal allele. So in Angelman, the maternal allele is deleted or mutated, and the silenced gene is paternal. Okay. So what happened would be that there is no maternal gene in the baby, and the paternal gene is already silenced. So the signs and symptoms would be different. It would be an inappropriate laughter. Okay, it would be seizures, hand clapping, ataxia, again, intellectual disability. Chromosome would again be 15, so you don't have to go to and fro. In both the cases, there would be chromosome 15. Mnemonic is mamas. So mama as in maternal gene is obviously deleted, so you know that by the mnemonic. And then mood, ataxia, and seizures. Okay, so this is the mnemonic for that you have to memorize. But once again, I'm telling you guys, they do not ask you that what gene is deleted or mutated. They always ask you that what gene is silenced. Okay, so that's what they ask you. Um, all right. So, okay, we're gonna do the modes of inheritance in the next class along with the UWorld questions. So I'm gonna merge those and make slides out of it so that it becomes easier for you guys. Um, That's what we're going to do, but we're definitely doing cystic fibrosis because this is very important as um accordance to in accordance to the pathology. Okay, so I get a lot of questions as to if you're supposed to memorize the autosomal dominant disease and autosomal recessive disease, and I'm sure you guys would have the same question, right? So my answer would be yes. Now, don't panic because I know this is too much to memorize, there's a lot of memorization, but just memorizing this would give you so much information about the diagnosis. Okay, because they do tell you at times that it's an autosomal dominant disease, for instance, and they don't tell you the name of the disease, they give you the characteristic and they tell you it's an autosomal dominant disease. And then you have limited choices to choose from because you already know what are the autosomal dominant disease. And in the same manner, sometimes they tell you the signs and symptoms and they tell you that this is AR, autosomal recessive disease. So I will not say that go through each and every disease and memorize it, but you know what you guys could do? You guys could read it multiple times, like a lot of times, and then some of them would at least retain in your mind, right? For instance, autosomal dominant disease, just read it time and again. I'm sure some of the diseases would retain. And then the same thing with autosomal recessive disease, read it a lot of times and some of them would stick in your head. And even if some of them stay in your head, you're fine. Okay. I know it's too much, but it's important. Okay, let's talk about cystic fibrosis. It's very important. They ask you so many questions about these. I'm just going to tell you the types of questions they ask you. They ask you the gene deletion. Okay, with the deletion is F508, the chromosome number, which is 7, defect in the gene, which is CFTR. It is the most common lethal genetic disease in patients with European ancestry. So they ask you all these questions, okay? So 3 questions are coming out from just from the intro line. So they ask you these questions. Now, what happens is that the CFTR gene is coded on the chloride channel, okay, which is secreting chloride in the lungs, in the GI tract, and the chloride is being absorbed, the excessive chloride is being absorbed from the sweat glands. What happens is that whenever the gene is deleted, the 508 deletion, there is improper protein trafficking, which means that protein gets absent from the cell membrane. Now, when this happens, the whole system gets bizarre. Okay, there's decreased chloride secretion, and because of that, there's just to compensate the decreased secretion of chloride, there's increase. The gland started taking more and more sodium from the epithelial channels and more water. Because obviously, as the chloride drops down, the sodium chloride pumps goes into action, and now more sodium and more water starts, reabsorption starts taking place. And because of that, now when there's so much reabsorption of water and reabsorption of sodium, there would be abnormally thickened mucus, which would be secreted into the lungs. So the baby would present with nasal congestion. The parent would come to you, usually would bring a 7-year-old boy to you, and they would tell you the doctor, My son is getting recurrent respiratory tract infections. His mucus is always plugged in. He always has runny nose and like, rhinorrhea and congestion and stuff. And he gets better, but then again, in a couple months, he gets the respiratory tract infection. It's been going on for a couple months, and I don't know what to do. This is a type of scenario they gave you in the U world, the same scenario. And then it has to ring a bell that, okay, this is the scenario of cystic fibrosis. But once again, they never ask you what the diagnosis is. They know that you know that it's cystic fibrosis. So they will ask you the chromosome deletion, usually, okay? Or the genetic defect, the defect in the CFTR gene. So that's what they ask you. They give you the whole scenario, but they ask you the genetic question about this. I hope I'm making sense. Okay. The patient would also, when you do the diagnostic test, the sweat test, which is very commonly done in CF patients, you would see that the chloride concentration is extremely increased. Okay, because chloride secretion has been dropped down. So now it's pooling up. It's pooling up, and that's why there is increased chloride concentration. So now, if there is increased chloride concentration, it could also present with contraction alkalosis, hypokalemia, because obviously you see that water is being lost, sodium is being lost, and when water and sodium is being lost, it automatically goes into alkalosis. The body automatically goes into contraction alkalosis and hypokalemia. Okay. So there's wasting of potassium, there's wasting of water, there's pooling up of chloride. So all of these things will now, like I told you guys, the patient would present with recurrent pulmonary infections. The mom or dad would tell you that my child has been getting sick again and again. And when you do the chest x-ray, you would see the nodular pattern. On the lungs, you would see there is opacification of the sign. Opacification means no transparency. It would be like a whitish halo, a whitish shadow. Okay, the patient would present with nail clubbing, with nasal polyps, all of these things. Okay, now this is very, I'm sorry I'm going into the details of cystic fibrosis, but this is very important. So many questions come from this particular topic. Okay, in cystic fibrosis, there is also deficiency of fat-soluble vitamins, which are ADEK, A-D-E-K. There's steatorrhea, because obviously there's malabsorption taking place, and that's why there's fatty stool, there's steatorrhea. There's biliary cirrhosis, there's liver disease, you will see meconium, ileus in newborns. It also causes infertility in males. Why? Because there's no vas deferens, there's absence of vas deferens, and because of that, the spermatogenesis would be unaffected, but there would be infertility in males. Also, there would be subfertility in female, because now the females would have abnormally thickened cervical mucus, and that would lead to stopping of the sperm from going to the ovaries and fertilizing the ova, which would cause subfertility in females. Okay, I hope that makes sense. Now, treatment. Um, they don't usually ask for the treatment, but it's important to know that symptomatic treatment is given, aerosolized Oronase alpha is given, hypertonic saline mucus. Why? Because we want the mucus to clear away, and it would only clear away when we give hypertonic saline. Okay, so lots of sodium and lots of water would clear the mucus. We're giving azithromycin, which is broad spectrum antibiotics. Why? Because the patient is going through recurrent respiratory tract infections. Then we will do the symptomatic treatment, which is ibuprofen. And in severe cases in which there is a lack of pancreatic enzyme, we do pancrelipase. But in severe pancreatic insufficiency cases, we do that. Okay. So I hope this is clear, because cystic fibrosis is very important. Okay, now as we talked about the X-linked, sorry, dominant and recessive diseases, these are the X-linked recessive diseases. I would say go through this. You don't have to learn them, memorize them, but just go through them so that if you go through them again and again, some of them would stick in your head. And that's extremely important, right? Okay, we have 4 minutes remaining, so I don't think we should start with muscular dystrophies, but this is important. So we would not be neglecting this. We would be covering muscular dystrophies, a little bit of muscular dystrophies. I would try to add a little bit of genetics in my next lecture for the first 30 minutes so that we could do a little bit of muscular dystrophies along with at least mitochondrial disease because they're important. And we would not be doing autosomal trisomies because everyone knows it. They're very common. I'm sure you all know it on your fingertips. So yeah, but muscular dystrophies are important, so we would be doing that, and that's it. I would be adding some UWorld questions for you guys so that you guys could do the heterozygous homozygous questions from there. Um, okay, so I think this is it. We are done with 2 hours. Uh, let me just stop sharing my screen. Okay, so in today's session, we did a little bit of the intro and the gross anatomy. Um, we did the 100 most important cases of the GA, which are extremely important if you want to pass anatomy. Those slides would be uploaded in the MedExam Expert website, so you guys can go through it again after this session. Just go through it one time so that those things that we skipped, the nerves and arteries and the vascular supply that you need to memorize should stay in your head. So all of these things, they require no concept because it's just pure memorization. So make sure you guys memorize that. And then we did a little bit of genetics. Now for genetics, I want you guys to go through your guys' first aid. Make sure that what we talked about, you guys go through it. Because if you guys don't, genetics is that one thing that if you don't go through it again and again, you will forget it. I myself had to study genetics yesterday before teaching you guys because it's been a while since I gave my exam and you forget genetics very easily. So I had to go through my notes and I had to go through first aid and all the notes that I made at the time when I was studying because I was going to teach you guys today. So make sure you guys go through genetics. Make sure you guys go through all those GA notes, the 100 important notes that we have done. And the genetics that we have studied today. In the next session, we will definitely add a little bit time. We'll give a little bit time to genetics. We'll do the UL questions along with a little bit of muscular dystrophies because that's important. And then we will move on to the next system that we have. Okay, so it was great teaching you guys. I hope you guys um took a little bit wisdom out of it. And if you guys have any questions for later on, you guys can always text in the WhatsApp group that I'm a part of and you guys are a part of as well. Drop your queries into that group and I would be happy to help you guys. If you guys solve UWorld of anatomy or of genetics, and if there's a question in which you guys need help, drop the question in the group as well. Yeah. So it was great teaching you guys. It was great seeing you all today. I'll be seeing you guys in the next session. I think I have it with you guys in a couple days. I'm not sure what the topic is, but yeah, I'll be seeing you guys pretty soon. Please, please, please read whatever we have talked about today. And I'll see you guys next time. Thank you so much.
Dr. Jaweria, before you leave, I'd like to speak to the students.
Yes.
Okay, so hello everybody. I hope you're all doing great. I'm Palvasha, course manager USMLE at MedExam Expert. I just wanted to come up here and thank you all for joining us today. It has been a pleasure having you all here for this orientation session. Um, we hope this gave you an overview of what to expect from our USMLE course. This session was just the beginning, foundational introduction, you could say. Moving forward, each session will delve deeper into the core modules, ensuring you receive comprehensive guidance to excel in your exam. So, for those of you who haven't secured their slots yet, we still are offering a flat 50% discount. So, it's a great opportunity to join our course at a reduced price and maximize your preparation with us. Once again, we truly appreciate your time and trust in our program. We look forward to seeing you in the upcoming sessions and supporting you on your journey to success. You can always contact us on the given numbers in the chat box, and we could provide you with all the information about the courses. Thank you so much, everybody, for joining us. Thank you.
Thank you, guys.